My name is Dinah Siatu, Certified Optometric Vision Therapist. March is the Brain Injury Awareness Month, and who better to educate us and share with us than Dr. Daniel herself. She is the immediate past president of the Neuro-Optometric Rehabilitation Association. She is a current member of the College of Optometrists in Vision Development and also in the College of Syntonics. Her experience as a neurodevelopmental optometrist allows her to travel all over the world, giving talks and lectures, not only internationally, but here around in the United States. So I'm really excited about tonight's topic. I know you have a lot of information to share, so I want to get right into it. Ladies and gentlemen, please help me welcome Dr. Susan Daniel.
Welcome, everybody. And tonight's topic is on brain injury and concussion and how vision is connected. I've been practicing since 1992 with my husband, with Daniel and David's Optometry. And as Dinah mentioned, I am the immediate past president of NORA, which is the Neuro-Optometric Rehab Association. I also work as a clinical preceptor for fourth-year optometry students who are wanting to learn more about neuro-optometric rehabilitation with two of the colleges, one in Illinois and one in California. I'm a consultant for the brain injury clinics at the local hospitals of Tri-City Medical Center and Scripps Hospital. And I'm a consultant and provider of vision therapy services for all of San Diego school districts for children who have neurological problems and developmental delays. So what is a concussion? It's the most common traumatic brain injury. It comes from the word concuttere, which means to shake violently. And it's from a direct sudden hit to the head. One of the common types of concussion is where in a whiplash situation where they hit the front of their head, it jolts back and hits the back of their head. So they have two parts of the brain that are affected. And it can cause some micro shearing of the axons of the neurons that are in the brain. And so even if you have a MRI or CAT scan of the brain, it may not show up as anything of any type of damage that is obvious on the imaging, but you can still have a lot of symptoms and problems. So what increases your risk for concussion? Children and older adults are more susceptible to falls, and that can increase the risk for concussion. Playing a contact sport or having safety gear that is not worn or it's not adequate, or having contact sports that aren't supervised by an adult. Being in a car, motorcycle, bicycle, or other accident, which can cause a blow to the head, or being hit or struck from any type of physical abuse. And in the military service, we see a lot of blast injuries where they can hit their head on the front or the back of their head. And we're near Camp Pendleton, so we see a lot of our military personnel with concussions. And one of these last ones most people don't know about is that if you had a concussion in the past, you're more likely to have and more susceptible to getting a concussion in the future. And I'll talk as I go through the lecture a little bit about why that happens. So some of the symptoms of concussion are confusion, clumsiness, nausea, and vomiting, difficulty with memory, headaches, irritability, and difficulty concentrating, sleep disturbances, cervical pain, problems with taste or smell, sensitivity to noise, and ringing in the ears. And very commonly, mental health issues such as anxiety and depression, and unusual reactions to stimuli. And what I mean by that is that they may be hypo or hypersensitive to sound, taste, smell, touch, and visual stimuli. And so they may be covering their ears because sound is too much. The movement or being touched is very uncomfortable, but it's more exacerbated because of that concussion. So some of the things that we look at and how they're related to those common concussion symptoms are what we see that are been affected visually. And the first one is light sensitivity, or what we call photophobia. And it's very common because once you've had a concussion, you can be in a state of fight or flight. You're in shock, your pupils dilate, your heart is racing, and you're like running from the bear because you're in a high anxiety situation. When your pupils stay dilated, though, then they don't constrict when presented with light, and you can be more light sensitive. The other things that can happen is that certain types of light might be very uncomfortable, such as fluorescent lighting and ones that have a flicker frequency to it, because or a buzzing to it, because those can be very distracting and uncomfortable for patients. Double vision. Double vision is caused by the two eyes not coordinating together as a team. And it's very disturbing because things are not where you think they are. You'll see an image that may be vertical presented, horizontal, or even in a turn position, and it's very confusing. You may have blurred vision, and that's due to the lens that's on the inside of the eye being affected. The lens, the brain sends signals to the muscles of that pull and relax the lens that's on the inside of the eye that changes your focus from near to far. So even if you had perfect visual acuity with no glasses, you may experience blurred vision after a concussion because that lens can go into a spasm and it doesn't relax fully or constrict fully to see far and near. It can also fluctuate to where it goes blurry, clear, blurry, clear, and that trying to make it clear can give you a headache, both in the front part of your eye, the side, or in the back of the head. You may have a visual tracking delay, and that is the ability to for the eyes to fixate on a target and be able to follow it in all different gazes and be accurate and in staying on fixation. When you have a visual tracking delay, the object may be going at one speed, but your eyes are not going at the same speed of the object. It may be going too fast or too slow, and it skips. And what happens when you have that visual tracking delay is that your perception of where things are moving, like a ball coming towards you, you wouldn't be able to judge the distance from that. And things may feel like they're closer than they appear, and that can increase anxiety. And you may cause more tripping and falling and that clumsiness. What many people don't know is that a vision problem can cause postural and movement changes. We have two visual systems. We have our central visual system and our peripheral visual system. Our central system is what is responsible for discrimination. It can look at something and see what is it, and it can see very small things. Our peripheral vision tells us where our body is in space. It also detects light and movement, and it is stabilizes us. And it's a much slower system. The peripheral vision does not have good visual acuity. It can't discriminate things that are small. It can see big things and big things that are moving, but not small things. Now, these two visual systems have to work in coordination. Otherwise, things start to fall apart. Our peripheral vision may have a light that's moving over here. You don't know what it is, so then you look at it with your central vision and then you tell what it is. So if you have a car that is coming by, you can see there's movement there, and then you look at it and you go, oh, that's a car, or that's a child, or that's a ball. Now, if your peripheral vision and your central vision are not working together as a team, which is very common after concussion, then when you are fixated on something, your posture can change. It falls because our body doesn't know where it is in space. And this is where, as optometrists, we can make a big difference in changing that posture to be more efficient and help these people walk without dizziness or disorientation. Now, this one of the other things that can happen is that they have visual motion sensitivity, and there might be some people that are watching this that they look at this train and it makes them feel nauseous. Their stomach can churn because this motion that's in the peripheral vision is disturbing. And part of that is too with that tracking ability that we don't have the stability of our central vision and our peripheral to work together as a team. And so this movement is overwhelming. Now, what's interesting about this video is that when you're looking at it, if you're imagining that the train is coming from your right and moving to the left into the tunnel, it's going that direction. But if you imagine that the train is starting from the left through the tunnel coming towards your right, you see how the train is now going in a different direction. And that shows you how powerful our brain is in suggestion, and that what our brain has developed over our lifetime is expectations of what is normal, and it does predictions. And a lot of that prediction and experience goes back to starting point again after a brain injury. And so it can be, you have to learn things all over again, just like having to learn to walk again or eat again or speak again. We're having to learn how to see again. And I like this video because it's pretty powerful to see how your brain can change things just by looking at them. The other thing that people come in with a complaint of is difficulty reading after they've had a concussion. And this is with a lot of students. You know, they got an injury, they went back to school, they're trying to study and read, and they're seeing double, they're seeing blurry, the words are moving around on the page. It looks like the words are floating up towards them. And that makes it very difficult to read. It has to concentrate very much on the physical part of reading because these eyes are not focusing and working together as a team and tracking, that then the comprehension isn't there. You don't remember what you've been reading. And there can be a perceptual visual field constriction. And there's there's actually 3 types of visual field problems. One of them is that the nerve on the inside of the eye is damaged somewhere in the brain and in the pathway, and it can cause a visual field loss where say a quarter of your vision is just gone in your peripheral vision, or half of your vision. That's called a visual field loss. There's another type of visual field problem called visual field neglect, or spatial inattention. And that's where you're just not aware of a certain part of your periphery, usually on the left side for people who've been hit on the right side of the brain. And the third type, which is the most common with concussion, is a perceptual visual field constriction. And that is where, even though the nerve might be fine, the optic nerve, they don't have a actual field loss when testing for field loss, but their perception of their periphery, they're just not aware of it as much as they are with their central system. And so they may be looking like tunnel vision and not aware of their periphery. And this is why, if you've had a concussion before and it wasn't treated, and you still have this peripheral visual constriction, why you can hit your head again. You hit your head on an open door. You walk into something because you're not aware of that periphery, and why people can get multiple concussions. Especially if you're in movement. So if you're riding a bike, or you're running, or you're jumping, then it's even more focal. And so that can affect. I've had patients with 6 and 7 concussions, and they're like, "Why am I always the one that's getting a concussion?" I was like, "Well, that's because of these peripheral vision problems. And once treated, then their susceptibility for getting another concussion is the same for the rest of us." And we talked a little bit about decreased depth perception, and that has to do with the two eyes working together as a team. Now, the brain has different nerves that send signals to the eye muscles that are around the eyes. There are 6 muscles around each eye, and one a muscle will move the eye in or out, up or down, or in a cyclorotation. So you have the image of the right eye and the image of the left eye, and those images must overlap and fuse and make one percept. And when it makes one percept, then it has depth. If the eyes are not coordinating well together as a team, one eye turning out or up or in, then it affects your depth perception. And then you're more likely to be clumsy or increase your risk of falls again. And that's why when you, because these cranial nerves go through the brain, when you have a head injury, it's very common to have these depth perception problems. So why should vision be evaluated after a concussion? And I think they should be every time, is because 70% of the brain is dedicated to visual processing, and 80% of all sensory processing in the entire body is directly affected by information coming in from the eyes. And 90% of traumatic brain injury patients experience those eye movement dysfunctions and eye teaming dysfunctions. 90%. That is just so much. And 40% of them have these dysfunctions that persist longer than 3 months. And so some of my patients that I've seen had a concussion 20 years ago, 30 years ago, and it was never treated. And they still have these vision problems because they weren't identified and treated. So the problem with vision is that when you have a vision problem, it's not obvious to others, and it's not always obvious to the person who has the vision problems. That they think that it's not related to vision. I just have headaches, or I don't like to go grocery shopping because there's just so much movement. I keep bumping into walls and furniture. They get nervous and anxious when they're going down the stairs because their depth perception may be off. They hit their head again and again getting in the car because of that peripheral vision problem. And they just feel off or insecure because their balance and their posture may be off. And they don't like to go walking in crowded areas, and they can feel dizzy. Whereas if you had a speech delay, other people would say, you should see a speech therapist. Or if you have a physical problem, a physical therapist might be a great idea. Or some cognitive executive function problems that an occupational therapist may be great for you. But they don't think to always refer to a vision specialist because it's not an obvious problem. So the constellation of these things that I've been talking about are called post-trauma vision syndrome. And the most common type of eye teaming problem is called convergence insufficiency, where the two eyes do not converge well to see things up close. As the eyes look at an object coming towards them, one eye will start to turn out, and then that's when they see double vision. It's the most common type. They may have what's called a visual midline shift syndrome, which means that the perception of where the middle of their body is not where the actual middle of their body is. They can perceive that the middle of their body is over maybe to the right, and this is the middle, so I must lean into that middle in order for me to feel like I'm straight. But if you're leaning like this, the physical therapist moves you up straight and you feel like you're falling down because your percept is over here. And the reason why I mention that is that we have optical aids that can shift that percept to be where your perception of midline is the same as actual midline. And it can be an immediate improvement in their ability to walk. You'll see their speech improve. You'll see their posture realign. And I have some videos to show you about that. And we talked about the other things on there. So neuro-optometric visual rehabilitation involves many different tools and therapy. The first thing that we do is we do some diagnostic testing. This is different for every person that comes in, depending on their symptoms and what we find in their examination. They may have some extra specialized diagnostic testing, like the gentleman on the left has some sensor goggles that have sensors that measure how his eyes are moving as he's reading, and we can see on a graph whether they're shaking, they're going too far ahead, they're jumping, skipping lines. All of that is documented, and so that after therapy we can do the same test and measure the difference. The gentleman on the right is having it's called a visual evoked potential, where we put sensors on the back of his head and the front of his head. He's looking at a checkered pattern, and it measures how the brain reacts to the visual information that's being presented. And what we do is that then we use different lenses and sometimes tinted lenses and different types of occlusion on glasses and remeasure those same brain waves. And we can tell what type of lenses are going to be best for that person in improving their symptoms by using this technology. Many times we don't need the technology, because just using those lenses, the patients tell us, wow, that's so much better. And so then we can just use that. Now, these are 4 of the big tools that we use as optometrists. The first one in the top left are using different filters. Filters are different gradations of wavelengths of light or colored tints, and each tint has a different effect on vision, in that in the color spectrum of the rainbow, the red tint is a sympathetic nervous system stimulator, which means it stimulates the fight or flight response. On the blue end, it stimulates the parasympathetic nervous system, which is our rest and relaxation system. So if you're in fight or flight and we want to relax the system, and to rest and digest by using a blue filter. So blue is actually one of the most common tinted colors that we use for the treatment of patients with concussion and relieving their symptoms. But the other tints may be used as well. For some of them help with images that help the brain bring together the images when one eye wants to drift up. Some of them help with eyes that want to turn in, but they're a very powerful tool. The type of lens that is on the upper right is called a Yoked Prism. And a prism is a type of lens that shifts the image of what a person sees when they wear them. So if they put on those glasses, the image of the world would shift over to the left. And so this type of lens works great for those people who have a midline shift, to where the perceptive, where their midline is shifted over, like I was talking about. We can move basically the image of the world to center them. And so we do different testing to see how the posture and their vision and their processing works with these type of lenses. The bottom left picture it's hard to see, but there's a tape that is on the lenses, and it's called binasal occlusion, or it's occlusion on the nasal side of the glasses. And what that does is it takes away some of the visual confusion that the patients see, and it's one of those instant relievers of confusion, especially early on in the concussion recovery. And then we use many different types of lenses, and both magnification and minification lenses to help improve the focusing system, to improve their peripheral awareness, and many other utilizations. And this is what's unique to both optometry and ophthalmology, is being able to use these optical tools in rehabilitation. So this is an example of a person who had a concussion whose depth perception was really affected. And it's a very simple test in that we just have them hold their hand up and try to touch the ball as quickly as they can. And so you'll see with this gentleman in the video how his depth perception was affected. See how far off that is. So when, and I'll show that again. If you can imagine that you think that everything is shifted over that far, why that person would be clumsy and trip and fall and run into things, because everything is shifted off to the one side. For this one, after just a couple sessions where we were working on fixation and being able to tell location of where things are, you can see his ability to touch the ball is much easier. So this one is some of the midline shift testing that we do. So this woman it's a simple test. It's not so simple, but it's simple, where the patient will walk down the hallway. And what I'm looking at is their shoulders, are they moving their arms back and forth? Because that's a more fluid system. Are they bracing themselves? Are they have their stance wide to give them stability? Do they have heel to toe movement when they're walking? And how do they feel after they've walked down the corridor here? So with the, what we use then is those Prism glasses. And what the Prism does is, again, reorganize the space for that particular person. And we do test the Prism in different directions to see which one works to make that posture and that movement more fluid.
What does that feel like? Better.
So you can see that even she was moving her head and walking, whereas before it was very like stiff and much more disorienting to her. And so that helps with guiding whether we prescribe Prism in glasses or we use different therapy techniques to reestablish where that midline is, or both. So this gentleman had a severe concussion, and when he came to me in the beginning, he had not been, he had been in a dark room for months because he was hypersensitive to all sensory stimuli, severe pain with his eyes, with his head, and very photophobic or light sensitive. And even getting to our office was a challenge because he had to be in a car on a long drive to get to our office for the evaluation. We were doing testing with just walking down the hallway, and you'll see this is his reaction just to his orientation. And how he has to be grounded to stand against the wall because everything's so dizzy and moving on him that it's too much for him. So this is a video of a different day, but we were trialing some Yoked Prism for him as well to see if we were going to put that Prism in glasses to help him. And we have done some therapy as well, but you can see the difference with his walking here.
Wow, this is great. That's so cool. Yeah, that's weird.
Yeah,
Great.
I like that one the best.
I actually saw the hallway, not just like where I'm trying to look.
And you can see he was explaining exactly what we were talking about, is that he's seeing the whole room rather than just that central focusing that we were talking about. So the other thing with him is that we had seen him about 10 months after his injury, and he wasn't able to read anymore. He couldn't look at a cell phone or a computer or print or anything, and he hadn't read at all. So I was thinking he was doing well with this prism, and so I was challenging him, and I was like, let's put it on tape and see what you think. So this is the first time that he has read since his injury.
Read yet, but I just wanted to see how that makes it to where you're trying to decipher words and look at the same time.
Jill likes to play with the animals on her farm. The cow she likes the most is all black. One day she took she took that cow some milk. 2 other cows wanted the milk too. The other cows bumped her down. This makes no sense. She called to her mother for help. Her father saw her and ran to help. Now Jill stays away from the cows.
Now go ahead and take off the glasses. See the difference between the two.
Judy has one pet. Her pet is white. Judy feeds her. I keep going in front of it. Judy feeds her pet every day. It does not like dogs or cats. It is not a rabbit or a pig. It plays in the water. Judy has to run very, very fast to catch her pet. She keeps her pet in a cage. Can you guess what animal Judy has for a pet? She has a pet duck.
What does it feel like, the difference between the two with the lens versus without it?
Oh, it feels horrible. I can without the lens, I can feel my eyes jumping forward and then also up. My comprehension is way down, and it's more uncomfortable to read.
So we were coming out of our skin super excited that he was just reading, and so was he. So this was great to get on video, and he's now working more with doing reading and on a computer screen now.
Read yet.
So what we do to stimulate the central vision along with the peripheral vision simultaneous is that we do an eye movement activity along with a balance activity. Remember, our periphery tells us where our body is in space, and so if we have a patient where they have to tell where their body is in space, that's stimulating the peripheral vision. And then while they're doing a tracking and trying to keep their posture while they're tracking. So this gentleman is in a wheelchair, and he's not able to be standing to do any kind of balance activities. So we have him sit on this type of cushion that kind of wobbles. So he gets a feedback of where his body is. And he's looking at a marble that is going in that 8 position, and he's having to move this in the marble and track the marble going around in an 8 position. Now I want to do a little activity with you, to those in the audience, and this is one of the activities that we do that has a cognitive demand as well as an eye movement demand. So the first thing I want you to do is first look at the green dot. Now shift to the red, then green, red, green, red, and that was pretty good, right? So now I'm going to tell you to do the opposite of what I say. So when I say green, I want you to look at the red dot. And when I say red, I want you to look at the green dot. Are you ready? So green, red, green, red, red, green, green, red. How many people had difficulty with that? Yeah. Because we think, oh, eye movements, not so hard, but they are hard when you have to do something else at the same time, to where you're having to think and have balance and do an eye movement all at the same time. So here's a gentleman who has a visual field loss. Remember I talked to the 3 types of visual field problems. So he has difficulty with his with one side of his vision. So we have him doing this activity where he's pressing a light on a board, and it goes in time, and whenever he presses it, there's a new light. So he has to be aware of his central vision and his peripheral, and being able to switch back and forth between his 2 arms to push the button. And the reason why alternating the arms is important is because it's stimulating each side of the brain every time he alternates with his hands. And we also have him on a balance board, and that is so that he's aware of his periphery while doing this central task. Let me show you this. And he's doing very well with this. He's had a few sessions with us, and when he first started, he couldn't find any of the lights flashing on one side of the board, and now he's able to search and find the lights. So he's doing very well. Sorry. So accommodation, that's another word for focusing, and not the pay attention type focus, but the focusing of making things clear and single. So what we use is those different lenses, and a Magnification Lens and Magnification Lens relaxes the eyes and then constricts the eyes, relaxes and constricts. So it's a therapy tool in order to train that lens to be more flexible and have less of a spasm. So this woman is holding a little chart of small letters, and pretty close. She's looking through one side of the lens to where her eyes have to relax to make those letters clear. And then she switches the lens, and now she has to constrict or try hard to make it clear. And then we're flipping back and forth, so it's getting that flexibility back. But we're also doing this with movement of her periphery, where she has to maintain her balance while she's in movement, because she also has symptoms of that visual motion sensitivity. Whenever things are moving, then she gets nauseous. So she's moved up to this activity. We start with her first sitting and doing just the flippers, and then we get it to where she's standing, and then now in a moving situation. So we have her on a swing.
How's the movement?
Okay. ZR EH FB AB.
And this activity, she's sitting, but what she's doing is that she has special filters on. And the filter, she has a red lens over her right eye and a green lens over her left eye, and a magnification lens on one eye and a minification lens on the other eye. And what that means is that when she's looking at these little pictures, only one eye can see it. The other one sees a blank picture. And so she has to focus one way to see the cue with one eye. And then, but the other eye still sees peripherally. And then she's looking at the red screen, and there's some pictures on there, and she can only use the left eye in order to see that. So it's also a training tool to test the flexibility of the focusing system, and also
Is there one
discrimination.
eye or the other that you feel like you're seeing them better with?
What is this one?
The right one?
Yeah.
And what she's doing is she's matching the pictures that are on the cards to the pictures that are on the that red film. And it's a pretty difficult task, but it makes it to where that improves that flexibility between the eyes and the periphery. Now here's another exercise for you. These are called eccentric circles, and about half of you in the audience will not be able to accomplish this correctly, but I want to have you give it a try. So what this does is it works on getting the two eyes to see depth. And so if you have a pen or a pencil or just the tip of your finger, I want you to put it in front of your computer screen and place it at the lower end of the cards. And your finger or the pen should be halfway between you and the pictures that are on the screen. So when you're looking at the tip of your finger, you should notice in the background that there's those two big circles with circles in between. As you bring your finger closer to you, you'll see in the background, without looking at the background, but you just notice in the background that those circles come together and form a third circle in the middle. And when you get that third circle in the middle, then you'll see some depth perception. And did any of you get that?
Yes.
Oh, wonderful. And so you'll see in this next one, this gentleman is looking at these types of concentric circles straight ahead, and he's seeing this depth. Now, if the eyes are not coordinating and focusing in this free space to make that depth, the circles go flat and he won't see that. We're having him stand 1 foot in front of the other, so it's challenging his balance. And then we're testing his peripheral awareness by throwing a ball at him while he's doing the same thing. So it's a central peripheral task that involves balance and coordination. Timing and cognition. Now this is another exercise where we use those prism lenses in order to reestablish fixation and peripheral awareness. So this, we have a ball on the string that acts like a pendulum. So it's easier to tell speed and location, and the ball won't hurt them because they can, if it touches them, it'll still just be hanging from the string. So we use this ball and the string a lot in vision rehab therapy. The patient is having to alternately touch the ball and try to keep it going straight back and forth. And again, that alternating movement stimulates both sides of the brain when she alternates. But then we make it harder by having her on a balance beam and also using the prism lenses. Now what we do is we put the prism in one direction, so it moves the ball, the percept of the ball, to be in a different place than where the ball actually is. And we see how quickly her brain can adapt to that. Then we move the lenses to where now the percept of the ball is in a different spot. And what it does is make the brain having to adapt quicker to changing visual scenarios. So let me show you how she's doing this. And it may look easy with somebody that's watching, but it's actually a pretty difficult task. And we first start this task with just wearing the prism glasses standing, and then sitting, and then with one foot in front of the other, and then on a balance beam. And then we may start adding it to where she has to do it to a metronome, or count backwards by twos, so that there's a cognitive demand. And there we start to what we call loading the system to where the visual part becomes an automatic skill, and not something that they have to work so hard in order to visually process what they're seeing. So here is a patient who has what's called left neglect, which is where he can see things that are on the left side and on the right side, but things that are on his left side are not as, he's not as aware of them as he is on things that are on the right side. So here is
On your
Dinah.
scanning, because of your injury, you have a left field loss. This exercise is designed to help you and make sure work on you scanning into your left field. I have alphabet blocks on the table. Most of them are on your left side. What I'll be doing is showing you a letter, and as quickly as you can, I'd like for you to find the letter with your eyes, and I'll be watching your eyes to make sure that you are indeed looking at the correct letter. Are you ready?
Sure.
Remember, as quickly as you can.
Q. Kill him.
Okay.
Solid. Hex. Okay.
Don't forget we have lots of blocks on your left side as well.
Lots of blocks.
Very good. On your scan.
Now, here's the same gentleman that we saw before, and this is he's now advanced quite a bit in his vision therapy program to where now he's doing those eccentric circles, converging his eyes, also being on a balance board. And he's doing where he's having to notice what these big numbers are on the side. And it's like 5, 7, 12, 11, 12, 2, 6. And he's using 2 flashlights, one with his right hand, one with his left hand. And when a number is called out, he's having to shine the flashlight on the number, but using his peripheral vision while he's still trying to get the 3 dimension in the center. Then he switching to the other hand for the next number, then the other hand for the next number. And you'll see there's this ball that's hanging from the ceiling. It's moving in front of those circles. So it's like when you were getting that 3D image, somebody's doing this in front of it. And the reason why we do that too is consider driving. Driving, we have to have depth perception and movement on the side, being aware peripherally, but also we have windshield wipers. So a windshield wiper, every time it goes back and forth, it can disrupt the eye teaming ability. And so this is multi-sensory training for him. It's pretty impressive. Now, we went to a different type of balance board that this one has a ball underneath it. And so the balance is forward, back, side, and not just side to side, but forward and back and in a circle. And so we wanted him to be stable, and so that in case the ball kind of flew from over him, he's not going to fall. So we're training his ability to have depth perception, be able to move his body while still having balance, and regain depth perception quickly. And this is without using his finger. He can just cross his eyes and get those three circles together. And he's hitting a ball at the same time. So he's using his periphery. And then with this one, he's also working on turning back and forth. So it stimulates his balance vestibular system by turning his head and still maintaining the balance. And this works for that visual motion sensitivity and being able to walk fluidly and being aware of that periphery. And it's also working on timing because he's hitting the ball, and the ball is he's estimating the speed in which the ball is moving, even when he's not looking at it. So let's see. So we also have another program at our office called the Sensory Learning Program. And it there's a video that I did a webinar just on this program that you can find on YouTube, on my YouTube channel. And just Google on the YouTube Sensory Learning Program Susan Daniel, and you can find it. But it integrates auditory, vestibular, ocular motor, which is eye movements, and using different colored filters to balance the autonomic nervous system. And in many of our therapies, we use this therapy in the beginning of the session and then do some of these other traditional rehab therapies that are more active and cognitive. And so this is one way that we measure the perceptual visual field. On the left, you'll see a bunch of colored dots in the center. That is where the patient is looking at the center. We're bringing a little circle that has a color, and he has to tell me when he sees what color it is. And you can see the periphery, he's not aware of the color until it's right in the center of his vision. So his peripheral vision has very much collapsed. After therapy, you'll see that now he's able to tell where the color is in the periphery, and he's much more aware, and much that peripheral vision has increased dramatically, so that he's much safer in maneuvering through his world. So we learn by doing. A lot of concussion research shows that resting for the first few days after a concussion is very important, but then you need to move. You need to start moving your body in order to get better. And because it's that interaction with our movement with the world that rewires it, and so that it can work the most efficiently. So this is a video of the gentleman that you've been seeing. His name's Weston, and that he made for this webinar that tells you a little bit about his journey through this process.
My name's Weston, and I've been concussed for 16 months now. It was excruciatingly painful every single day. The world didn't make sense to me. When I opened my eyes, it was just nonsense. Sound was painful, and my lips wouldn't move to talk. I would spend every day in bed in the dark, and even the smallest amount of physical touch was intolerable. I got depressed, was having suicidal thoughts. Every day was full of flashbacks and mind-numbing anxiety attacks. Every night was full of the worst PTSD nightmares you could possibly imagine. I never want to go back to that. Dr. Susan Daniel at Daniel and Davis Optometry. During that session, she said something that I'll never really forget. She said, I'm so glad that you found us. I can help you. I believed her, but I didn't believe her. I had gone through so many horrible paths, and I just didn't want to have hope again. And the first session of therapy was about 5 minutes long, because that's all I could handle. All I did was I read a few letters back and forth on a whiteboard. And I did some midline stuff. And afterwards, when I got home that day, I tried to get out of the car and I just collapsed onto the grass and I couldn't move. My brain hadn't been worked like that in so long that it just kind of said bye-bye. A few weeks after that initial evaluation and after a couple of therapy sessions, Susan came to me during an appointment with her, and she went through essentially dietary guidelines. She went through what supplements I should be taking. She went through different meditation methods I could be doing, what might happen during all of this. She just laid it out for me. And she came to me and she's like, Weston, I am so excited because I have a laundry list this long of activities for the entire time of your therapy. It's gonna be long and it's gonna be hard. It's gonna be 6 to 9 months. But you know what? We're here for you and you can do it. And I'm like, that is so cool. Can I see the list? And she said, no, Weston, because if I show you the list, you're going to try to do the entire list, and then you're going to end up on the floor again. And I said, yeah, you're right. But that's kind of how it went. With her and with my therapist, Melissa. Melissa was awesome. She was patient. She was kind. She pushed me. She was there for emails and like always just supportive and coming up with new stuff for me and hand in hand, because it was a team thing. It wasn't just Susan, it wasn't just me, it wasn't just Melissa, it wasn't just my family. It was all of us together. And that's really how I felt the first day I even walked into that place, because it felt like family. It didn't feel like a doctor. So soon we added in sensory bed too, and that was like night and day. There was a separate video on that one, and I love that thing, can't talk enough about it. And so what started out with a minute of homework a day became 2 minutes, and then 3 minutes, and weeks went by, and months went by, and it turned into an hour, and then 2 hours. It was like someone had taken my perception of the world out from the dirt, dusted it off, and then put it on a shelf higher than it's ever been. And the world just sung. And it had this shine that I'd never seen before. 6 to 9 months was the estimate for how long it would take me to heal. And last week I graduated at 5.5. We haven't gone through vision therapy. And what would have been my normal for the rest of my life had I not met Susan, I would have been incapacitated compared to what I used to be. And that would have been my life. But now, I'm going to be more than I've ever been. So all I can say is that if you're going through this, you aren't broken. You aren't alone. And you will get through this. Enjoy the process as much as you can. These people are here for you. Trust that the people around you care for you, and you'll get better. It's going to take a long time, but you'll get better. So, thank you for listening, and just thank you.